Okay, well, let's begin, everyone. Good morning, good afternoon, good evening, wherever you are. It's my pleasure to welcome you. My name is Shekufe Zanji. I'm the Global Technical Lead with the Early Childhood Development Action Network. It's truly our pleasure to co-host this webinar with the World Health Organization and the International Pediatric Association. Really quickly, the format of our webinar will be hearing from speakers. We'll have a panel discussion and some Q&A. In preparation for the Q&A, we would love to hear your questions. Please submit your questions in the Q&A box and not the chat box. To introduce yourself in the chat box. In the Q&A, you'll have the opportunity for voting for questions you find most interesting and even responding from your own experience. With that said, without further ado, it's my pleasure to introduce Dr. Anshu Banerjee from the World Health Organization to kick us off with some brief opening remarks. Over to you, Anshu.
Thank you very much, and I'd like to welcome everyone to this webinar, and I look forward to this program. We'll be having a couple of speakers really digging into the impact of secondary smoking, and I think with no further ado, we should kick off with the program. And Bernadette, I think you're chairing the first session.
Thank you very much, Anshu, and welcome to all our guest participants on the webinar. So I'm going to ask my colleague Hebe to put on the slides. Hebe? Shikufa already has introduced us to the program that you can see on this slide. Next. Next, please, Hebe. So we start with our first part that looks at a smoke-free world, why it matters, and how we can get there. So within this panel, next, Hebe, we have three speakers. First, Dr. Banerjee, who you just saw, who is the director of the Department of Maternal, Newborn, Child and Adolescent Health and Aging in the World Health Organization in Geneva. He will be followed by Dr. Philippos Philippides, who is joining us from Imperial College in London, and who is a senior lecturer there. And actually, Dr. Philippides will represent a team of scientists that has supported WHO in preparing the brief, and so he will bring the evidence to it. And then that will be followed by remarks from Dr. Vinaya Prasad, who is the unit head on no tobacco in the Department of Health Promotion in World Health Organization, and he will focus on the actions. Before I hand to Dr. Banerjee, I would like to acknowledge that this webinar is a joint convening of the World Health Organization with the International Pediatric Association and the ECD Action Network. And so we are very grateful for these partners coming together. And we wish all of us a successful deliberation. And we hope that through this webinar, we will get new ideas of what we can do in our respective work spheres in order to advance the agenda of giving every child a best start in life. Dr. Banerjee, over to you.
Thanks very much, Bernadette. And maybe next slide. We wanted to kick off the webinar just with an introduction of where we are in child health at the moment. And initially, the focus was very much on the Millennium Development Goals and on mortality. But as we moved into the Sustainable Development Goals, the whole issue of multisectoral action became much and more important. So we came up with the Global Strategy for Women, Children's and Adolescents' Health, which highlights multisectorality also as one of its main domains. In relation to that also, we have the Nurturing Care Framework that highlights 5 domains from nutrition, stimulation, health, etc. And we also came up with the Adolescent Accelerated Action for Adolescent Health. And that also very much is having a multisectoral framework. Having looked at this, we are now developing really an agenda for child health more globally from 0 to 19 years that really looks at different domains and how we can improve health and well-being for the child and the adolescent. Also last year, we came out with a WHO UNICEF Lancet Commission looking at the future for the world's children, And one of the main recommendations also was really to strengthen the multi-sectoral action around child health. Next slide. So in relation to that, we know that childhood and adolescence are periods of really rapid physical, cognitive, social, and emotional development. And this is where a number of risk factors have major impact. And this is not only for the child, this is already important in the preconception period and also during pregnancy. And so what we're really going to look at today applies not only for the child, but also for the mother, the father, the preconception period, as well as the pregnancy period and post-pregnancy. And so looking at these risk factors, some of them are, of course, risk factors for non-communicable diseases, such as nutrition. We know that childhood obesity is an important area that needs attention, but smoking is another one. Next slide. And so tobacco poses major risks for children's survival, health, and development. And it's therefore very important that we protect them from the harm of tobacco, either in the adolescent period by preventing or ensuring that children don't start smoking, and that we can also give them the right kind of information so that they're not influenced by advertisements, etc. But it's also important to prevent or to protect children from secondhand smoke. And so it's important, therefore, to really have very comprehensive smoke-free policies to optimize human capital, not only for the current, but also for the future generation. As I mentioned, you know, it also applies to preconception care, etc. Next slide. So we therefore developed together with partners this thematic brief on tobacco control for child health and development. And this is available. And today's seminar is really going to drill down into this policy brief, let's say, to highlight the key components that have been highlighted in it. And next slide. The brief has been developed together with our colleagues in the Imperial College in London, and as well as with our colleagues in the Sophia Children's Hospital in Rotterdam, or the Erasmus Medical Center Sophia Children's Hospital in Rotterdam, and is supported by our partners with ECDAN and PMNCH, as well as UNICEF and the NCD Alliance as other contributors to it. So having given this very short oversight and introduction, I'd now like to introduce Dr. Philippos Philippidis, who will take us through some of the risk factors in relation to tobacco's impact. Over to you.
Hello, everyone. Thank you for the great introduction. Very happy to be here and present a summary of what we included in this thematic brief. And as it was said already, this is very much a group effort. And two of my colleagues that worked on this, Dr. Slaverty and Ben, will be around to answer any questions during the panel discussion later on. So let's go to the first slide, please. Children can be exposed to the harms of tobacco at different stages in their lives. First of all, through maternal smoking during pregnancy, which is something I will discuss later on, but also secondhand exposure to tobacco smoke is a major issue, both during pregnancy and in the first years of life for children. And this is particularly relevant to low and middle income countries where very few relatively women actually smoke, but many men do, and the culture of smoke-free environments is not that strong. So there's a lot of potential for secondhand smoke exposure. And of course, children are targeted by the tobacco industry. We all know that. So they can start smoking themselves in quite early in their lives, and then they are destined to suffer from the impact of tobacco throughout their lives. Next, please. One can assess the impact of tobacco on child health at different stages. So, for example, during pregnancy, in terms of birth outcomes, in terms of health during infancy, for example, infant morbidity and mortality, but also later on in childhood. And there are studies that look at the impact of early exposure to tobacco well throughout adulthood, and I will mention some of that. Next, please. I will give you some examples, some studies among the many that have been done on the topic. I am aware that not all of you are very familiar with these kinds of graphs. I will be using a lot of meta-analysis. So I will explain briefly what this is. Meta-analysis bring different studies together from, they could be very different settings, and they produced a summary estimate of the association between here maternal smoking and birth defects. It could be any two variables, any two factors. So what we are looking at here is the numbers within the red shape, and it shows that, for example, in cardiovascular system, birth defects of the cardiovascular system are more likely when the mother is smoking during pregnancy compared to a non-smoking mother. Specifically, it's 11% more likely. This is what 1.11 means. And I'm not going to go into details, but you can see that across all the systems that were assessed, there is increased risk of birth defects if the mother is smoking during pregnancy. Sometimes it's not statistically significant, but there is a clear trend that we can all see there. Next slide. And the same is true for secondhand exposure to smoke. So not actively, so even if the mother is not actively smoking, if she is exposed to secondhand smoke, then there is a higher probability that there will be congenital malformations as an outcome of her pregnancy. And we can see the number we are interested in here is the 1.13, which is quite consistent with the numbers we saw before. So that means that there is a 13% higher chance that there will be congenital malformation when the mother is exposed to secondhand smoke. The next study, in the next slide, is again what happens when mothers are exposed to secondhand smoke during pregnancy, but the outcome here is stillbirth, and again, quite consistently, we see an increased risk. Next slide. Beyond mother smoking or mother being exposed to tobacco smoke, we can look at it from a slightly different angle, and that is paternal smoking. So this study here looked at paternal smoking both before conception and during pregnancy. And why this is interesting, I decided to include it, is because it shows clearly the dose-response relationship that we see in many of those studies. That means that the more you smoke or the more you are exposed to secondhand smoke, the higher the chances that something will go wrong. And here the outcome is leukemia, childhood acute lymphoblastic leukemia. And we can see that if the father, for example, in this in the right-hand side graph, if the father is smoking 10 cigarettes per day during pregnancy, then there is an increased risk by about 10 to 15%. But if the father smokes 20 cigarettes per day, then the increase in risk is around 40%. So the more smoking, the higher the chances that the child will develop leukemia later on. Next slide, please. And beyond the immediate outcomes that we usually think about when we're discussing smoking in pregnancy, we have seen that there are effects of tobacco even later in life. So in childhood and in outcomes that are not the immediate thoughts when we're discussing smoking. So this meta-analysis here gathered a lot of studies that looked at the chances of a child being overweight or obese, and potential associations with maternal smoking in pregnancy. And it is quite clear that if the mother is smoking during pregnancy, then children are more likely to be overweight or obese later in life. Next slide. But of course, beyond exposure through the mother or the father in pregnancy, you can have secondhand smoke exposure during childhood from any other source. So this meta-analysis here looked at exposure to secondhand smoke among children, and the outcome was asthma hospitalizations. And we know very well that asthma is worsened by smoking, by exposure to tobacco smoke. So you can see here that it's almost twice as likely for children who are exposed to secondhand smoke to be hospitalized because of their asthma. Next slide. And because of all these studies, and of course many more that we don't have time to discuss, the WHO has made the protect people from tobacco smoke policy one of the key messages in the Empower package. And that means that we should be introducing smoke-free legislation and protect children and adults, of course, from secondhand smoke. And we've seen that wherever and whenever this has been applied in countries, the benefits for child health have been immediate and quite significant. In the next slide, we can see so this is from Brazil. This is an example of what happened in a country when smoke-free legislation was introduced. So Brazil is a special case, and I think there may be discussion later on, because it has different states and they introduced smoke-free legislation at different levels and to different extents at different times. So we were able to investigate what happened in terms of infant mortality following the implementation of these policies. And you can see in the right-hand side, the red dotted line shows what would have happened if no state had introduced smoke-free legislation, and the lower dotted green line shows what would have happened if all the states have introduced a comprehensive tobacco smoke-free legislations. And you can see there's a significant difference, and over time, about 2 infant deaths per 1,000 live births could have been averted, which is quite significant, and it translates into thousands and thousands of deaths in a country as big as Brazil. Next, please. Of course, there are a range of different studies, and there are meta-analyses that show that immediately after smoke-free legislation is introduced, hospitalizations for asthma and respiratory tract infections decline quite quickly. But all these are individual examples, and I know it can be confusing. So I've created this summary slide in the end to highlight the main diseases and conditions that are linked to exposure to tobacco smoke for children. So parental tobacco use and secondhand smoke exposure during pregnancy have been associated quite strongly with birth defects, impaired fetal brain development, stillbirths, preterm births, and low birth weight, death during infancy, and asthma and overweight and obesity in childhood and beyond. And parental smoking in infancy, so in the early years, is also associated with asthma, respiratory infections, middle ear disease, other kinds of infections, again, infant deaths, but also residential fires and burns, that kind of accidents, and overweight, obesity, and metabolic syndrome. But beyond that, and this is my final word in this, is that the impact of tobacco use goes well beyond the immediate or not as immediate health impacts, health effects. Morbidity within the family. So if parents smoke, they die, they get sick, they die earlier, and that has devastating effects on the children themselves. The economic costs, impoverishment, the catastrophic health expenditures that are a result of those events can change a child's life. And also, children that are being raised in families that smoke are more likely to start smoking and at an earlier age. And that, of course, can define their health throughout their lives. So it is very important to limit that as much as possible. Thank you very much.
Thank you, Dr. Philippidis, for this very rich sort of overview with data. We could see from the chat that people are keenly interested in the information that you have shared. We are going to proceed now with Dr. Prasad, who is going to introduce us to the actions that can be taken to indeed create these smoke-free policies. Dr. Prasad, over to you.
Thank you, Bernadette. Thank you, Anshu, for this opportunity to work together with the sector which you lead on. And thank you, Filippo, for setting the scene in terms of why it is so important from the evidence which is coming out. What we have seen from the world of tobacco control is that sometimes it's thought that tobacco is a done deal, and we have a treaty and everything seems to be going fine. So let's not focus on that. On the contrary, tobacco control requires greater attention in the coming years to reap all of the benefits which we now know from the evidence which is already there. Next slide. So between 1999 and 2002, the countries negotiated the first treaty under the WHO umbrella, and that's the WHO Framework Convention on Tobacco Control. And even the second treaty was also part of this, the illicit trade protocol. So this has come into force in 2005, and we have 182 parties. So it's one of the most rapidly adopted treaties. It has a set of evidence-based measures to reduce demand for tobacco and also reduce the supply of tobacco. Next, please. The WHO then came out with an Empower package, which Filippo just reflected on, which basically picks the key demand reduction measures. And the implementation of the Empower package at the highest level of its implementation is so crucial. It's not just adopting smoke-free, but going 100% smoke-free, as came out from the evidence from Brazil, or raising taxes, just not raising taxes mildly, but significant increases in taxes. So the Empower needs to be implemented at the highest level. And each of these measures actually have an impact on child development. And we'll reflect on that. Next slide, please. But before that, let's look at the progress of Empower. We've been monitoring the progress since 2007. And in 2007, less than 1.1 billion people were covered in 44 countries by at least one of those policies. The report, which came out in July this year, shows that 5.3 billion people have been covered. 146 countries now have at least one of these measures. So there is progress, still uneven, but progress is happening. Next slide. So just to dwell a little bit more on why it's so relevant for the child development sector to look very carefully at each of these provisions. Now let's look at monitoring. Monitoring, the M of Empower. Now, the use of tobacco amongst children is not very well monitored. And we're looking at it from different trends report. The next one, which we are releasing next month, also shows that many countries are not monitoring tobacco use, especially the novel emerging products, and then products which are called electronic nicotine delivery devices, the e-cigarettes. So we really need to work through to see how countries can start capturing in different global youth surveys, global school surveys, and national level surveys. Then protecting people, and Filippo's reflected on that, so I will skip that. For example, warning labels. Now we have more than 100 countries that have put warning labels. And this is very important that these labels are clearly brought out, really show the harm, because children can see it. And it has been shown to be very effective. And then looking at E, the E of Empower. Now the tobacco industry has worked very carefully to continue to use surrogate advertisements, indirect advertisements, because direct advertisements banned in majority of countries. And they are targeting the children. And we brought this out very carefully in last year's World No Tobacco Day, as to how industry uses very innovative techniques, digital marketing techniques to target the children. And I think this is an extremely important area of work for many of us to continue to focus on. And then finally, taxes, because raising taxes is not just good for the economy, but it's also good for ensuring that these products are not affordable to the vulnerable groups, including minors. So Empower is so crucial, and we really advocate for pushing all of the packages together, not just one of them. Next slide, please. So focusing on our core theme for today's webinar, looking at smoke-free legislation. So if you look at progress in smoke-free legislation, we currently, from just 10 countries with comprehensive smoke-free legislation, in 2007, we are up to now 67 countries covering 1.8 billion people who have 100% smoke-free environment. And when I say 100% smoke-free, it is all about indoor workplaces, indoor public places. We've still not reached a situation where we're looking at outdoor open spaces, where some countries have already now started to look at that. And also smoke-free homes is not covered by legislation, but will require change of social norm and acceptance, which is what we have seen again from the Brazilian study, that enforcement of indoor public places by law leads to behavior change for smoke-free homes. Next slide. So this gives a picture of countries that have made progress. The 67 countries are in the blue. And what we also see is that many of the countries, which is showing white, have also made good progress, but they still need to do some bit of more in terms of covering a couple of indoor places. Next slide. So this is how it is. 67 countries have all of the public places covered, but there are about 29 countries like India, for example, which have 6 of the 7 public places completely smoke-free. So as soon as these 29 countries add up, we'll have more than half the world, which is covered by a tough smoke-free legislation. Then the only question is how well it is enforced and implemented. And that's something which we are now working on to see improvement in compliance. Next slide. So this is something which requires a longer discussion, especially in the child development group, because this is an area of deep concern. The recent WHO report on the global tobacco epidemic, the GTCR, was focused on e-cigarettes, commonly known as e-cigarette, of course, and we are continuing to monitor this. Now, there's a whole divided group in the public health community which is pushing for harm reduction. Now, harm reduction in respect to what? Are we interested in the 24% adults who smoke and wanting to switch and not finding a solution? Is this a solution to help them to quit? Are there other solutions? So that's a whole debate. Are we looking to protect the interests of the non-smokers, the majority of children, and where the country stands? So what our position at the moment in WHO is that these products, we do not know the long-term health effects. They are all the time evolving. It's not just one group of products. They are different. And they do contain nicotine, majority of them. So nicotine is harmful, well established. We are not seeing very good evidence that these are cessation aids. So again, that's very well established. And dual use patterns are very common. So that in its own creates challenges. And most concerning, and this is of interest, is that the industry is using this to target children. So of the countries that have even started to regulate, only 69 countries have put any minimum age restriction. Now that's really worrisome. Now there are 84 countries that have done nothing. Those that have done anything in terms of regulations, only 69 of them put some age restrictions. Countries have not restricted flavors, and everybody knows that the thousands of flavors which are out there in these products are getting to target the non-users, especially children and youth. And at the moment, we just have 3 countries that have actually got a comprehensive ban on flavors. So I think something really important for the child development, child health experts to look at this and to advocate within their governments and at the country level to see how this could be fixed. Otherwise, the lack of regulation of these products will lead to these products being really reaching at a very epidemic level for children. Already there are countries which have got more than 10% children, especially in the European setting, more than 10% of children and the US are already using these products. Next one. I would conclude here by just saying on the last sentence, thanks, is that the last systematic review, and Philippos has been part of many of our systematic reviews, what we are seeing is that children who are using these e-cigarettes are also 2 to 3 times more likely to move into conventional tobacco. And that is like the end of tobacco control. This is the 50th year when the World Health Assembly recognized that tobacco causes cancer. It's been 25 years since the countries decided to negotiate a treaty. So I think it will be really a full circle reversal if we end up having all of the progresses to stop. So we really need to see multisectorality in a true sense, where everybody supports the regulation of these products at the highest level. Thank you.
Thank you. Thank you very much, Mr. Prasad, and thank you very much to all 3 presenters. We have now set nicely the scene with understanding sort of the global context of how child and adolescent health and development is being promoted. We have seen the evidence of the harmful impacts of the use of tobacco exposure to secondhand smoke on children's health and development. And we have learned that actions can be taken, and that particularly young people are an important sort of group of concern, as they are our future. And so how they adopt behaviors and practice and their knowledge of what the risks are very important for the future. I'm now going to hand over to our colleague, Dr. Jonathan Klein, who is the Associate Vice Chancellor for Research at the University of Illinois in Chicago. Dr. Klein is well known as an adolescent health specialist, and he has a very deep interest in preventive services, use development, and tobacco control. In that capacity, Dr. Klein also has acted in the International Pediatric Association as a focal person and contributor to the brief. So it's with pleasure that I hand the floor to him. Over to you, Dr. Klein. Mm-hmm.
Dr. Klein, you're on mute.
It makes it easier to hear me if I unmute myself. You would think after almost 2 years of Zoom, we would know that, right? Good morning, good afternoon, and good evening. I am going to take us right into the discussion of some of the country experiences so that we can stay on track. And if you could advance the slide. Thank you. We're going to have four presentations of 5 minutes each by the following panelists. We have Dr. João Paulo Lotufo from Brazil, who works with the Brazilian Pediatric Society and at the University of São Paulo in Brazil. We'll then hear from Jerry Karianjahi, and please, all of you, forgive me if I mispronounce your names, who is very active in the Kenya Pediatric Association and leads a project with partnership with the American Academy of Pediatrics, Julius Richmond Center. We'll then hear from Dr. Yuan Zhang, who is Deputy Director of the Research Center for Health and Development and also Deputy Director of the Chinese Association for Tobacco Control in China. And then finally from Dr. Iman Palagan, who is Executive Director of the International Pediatric Association, and President of the Indonesian Pediatric Society and a member of the Council for NCD Child. So without any more delay, let's dive into the presentations. First up is Dr. Lotufo, and we've heard about the 27 states and the partial and complete laws in Brazil. What do these mean for the country? How are they being used, and what is left to do? What's next there for that? So I will remind the speakers that I'll turn on my camera again when you've used 4 of your 5 minutes, and take it away, Dr. Lotufo.
Thank you very much. we know that Brazil was able to reduce the number of smokers from 30 to 9.8% through organized political measures supported by NGOs and civil society. I showed that 24% of the children from 0 to 5 years old had positive urinary nicotine. These measures insisted on the increase of the cigarettes price, despite they are still very cheap in Brazil, between $1 to $1.50 each packet. Insisted on the tobacco advertisement withdrawal from the media and on a strong legislation which really punished those people who smoke indoor. The country also started to offer free treatment and medication to the population. Laws which established 100% tobacco smoke-free environments reduced the children mortality in Brazil. The more restrictive the laws are, the higher reduction of the infant mortality will be. In 2009, the state of São Paulo became free of tobacco in closed places. However, only in 2014 in Brazil. In this period, the implementation of the laws prevented the death of 15,000 children under 1 year old. In other words, reduced the infant mortality rates. Young people don't come to us in order to stop smoking. However, they start on legal drugs, alcohol and tobacco at this age. For this reason, I decided to work with the prevention of tobacco, alcohol, and other drugs. The idea is that they don't start because it's harder to stop it. The professionals who work with tobacco prevention work with prevention of all drugs, even because cannabis and alcohol are becoming the first drug used with an experimentation peak at the age of 14. The electronic cigarette isn't approved in Brazil, but has already been used by a small amount of the population. Next, okay. However, if we don't prevent the educate the youngsters, the legal drug experimentation rate may increase, and consequently, these positive cessation rates may go back in the country. According to Fiocruz research, 34% of Brazilian smokers declared they have increased the numbers of cigarettes they smoked during the COVID-19 pandemic, associated with the deterioration of mental health of tobacco users, the worsening of depression, anxiety, and insomnia. The prevention through the brief counseling is done by the pediatrician, health agents, teachers, and family members who talk to the children and families for some minutes, providing them information and security. My job as a pediatrician has been to motivate other doctors and health agents to get involved in this cause by working at the Pediatric and Pneumology Societies and Brazilian Medical Association. We also use a methodology of 12 steps to facilitate the family's understanding about the importance of drugs prevention. As for instance, investing in the family relationship, raise your children, do more cultural and sport activities, get involved in social works, spirituality, and the example of their parents. There is a lack of political will in the prevention because the policies are dedicated to the drug users' recovery. Next slide, please. We created a doctor character to instill good ideas in the children, and we have booklets about the topic and educational material on the website. If we don't avoid that the children start on the nicotine and other drugs dependence, especially in adolescence, an important period of brain development, we won't win this struggle. A part of our material is available on the site www.drbartol.com.br, translated into English and Spanish. Click on the arrows and make good use of this material. We have booklets, videos, and explanations about the Dr. Bartow Prevention Project. Thank you for this opportunity.
Thank you. Thank you so much, Dr. Latufo. That's a great summary, and I hope people will use the resources. We'll now move to Dr. Najuri Karianjahi, who's a clinician and active in the Kenya Pediatric Association. And Najuri would ask you to reflect on the role of practitioners and their professional associations with the work that you're doing in driving tobacco control and helping save lives.
Thank you so much, Dr. Klein. Good morning, good afternoon, good evening to all the participants. I'd request if you move to the next slide, please. So when we look at Kenya, tobacco control sort of snapshot. In 2005, Kenya became party to the WHO Framework Convention on Tobacco Control, and 2 years later, Kenya enacted the Tobacco Control Act. And as my colleagues had mentioned earlier, when you look at the Empower model, the Tobacco Control Act was able to actually tackle some of the elements, like in terms of the monitoring element, in terms of tobacco use, protecting the public, and this led to smoke-free areas being, especially outdoors and in public. And one of the things that we realized at the Kenya Pediatric Association, and somebody also mentioned in the chat, is that this talks about outdoor and public places, but doesn't talk about indoors, doesn't talk about homes. And tobacco is one of those things that we realized that if the adult or the parent is a smoker or uses any tobacco product, that their lifestyle directly has an impact in terms of the health of the child. And for us as the Kenya Pediatric Association, and just looking at our role in terms of towards children and towards their families, we realize that we can't just think about children and not consider what the impact is from the family and from the environment perspective. And so for us, in terms of looking at the Kenya Pediatric Association and what we could be able to do, we looked at what strengths we had. And one of the biggest strengths is that it's like an umbrella. And you physically think about an umbrella with its multiple spokes. We're able to get training from the American Academy of Pediatrics and the CDC. And with that training, we're then able to disseminate that information to our membership. And we had membership countrywide, and they were then able to disseminate it in their institutions and in the communities. And one of the biggest things that we're able to do was to teach people about screening. And with the screening, we're able to pick out more adults, more parents who needed support and also needed referral for necessary services. And in effect, then we were able to positively impact how children were then, their health was being impacted. So anecdotally, some people were able to report that they started seeing less asthma cases because adults were being more mindful about their tobacco use, and some had even gone to get some help. The other role that Kenya Pediatric Association has played is in terms of collaborative efforts, like the one we're having right now with IPA and the WHO, and those collaborative opportunities, creating spaces for us to be able to share information, to network, to be able to learn more, to be able to work better together. And that is much easier when you have the professional body, because that professional body already lends itself in terms of an accountability mechanism as well as a collaborative mechanism. We also were able to do that with the tobacco control unit and be able to support and get information out to the public about the work that tobacco control unit was doing. One of the things that we were really happy about and proud of is that as a result of our training and our education and empowerment, when Tobacco Control Unit requested for us to be able to send a memorandum in support of the ratification protocol against illicit trade, we were then able to also send a memorandum. And for us as Kenya Pediatric Association participated in terms of policy formation at the national level. And that is something that we were very happy about and very proud of. And so I thank you so much for having given us this time to be able to share that with you.
Thank you so much. A great summary of what's been going on there. I would remind people who are putting questions into the chat that if you have questions, to please put them in the Q&A so that they can be tracked and answered, because there's quite a nice discussion in the chat, but I don't think we're going to be able to have panelists answer there. Let's move on now to Dr. Wan Jiang from China. Despite regulation, there's still a lot of tobacco use in a lot of countries, and young people don't seem to worry that much about it in many cases. Tell us what's been going on in China and how young people are part of those efforts, please.
Okay. Good morning, good afternoon, and good evening. Can you hear me?
Yes, we can hear you. You're fine.
Okay. Yeah. Good morning, good afternoon, and good evening. So thanks for giving me this chance to share some experience in China. Before I introduce the involving youth in China, I want to introduce some background in China. So the FCTC ratified in China is already for 15 years. So so far we have about 20 cities. They have a total ban smoking in the public place in the indoor area. So it's cover about 14 peoples. So it's not too big serious. And also we do the monitoring. So we found the rate for the secondhand smoke exposure have already decreased in some industry like the hospital, like the government building, and also the school. But so far in China, we also still have more than 3 million current smoker. And every year we have about 2.6 million people die attributed to the smoking and secondhand smoking. Tobacco control is a very big challenge for us. And the good news is that we have a Healthy China strategy 2030. That in this target we have very clear target that at that time period, at 2030, that smoking rate should be less than 20%. And also we should have the more than 80% people protected by the smoking-free law. So we move to the youth. So in China, last year, we passed a new law. It's a law on protecting of the mirror, and it is into force effective in this first June. So this is the first national law. It's a focus on the tobacco control for the teenager and the young people. So in this law, that is smoking is prohibited in the place, not only school, maybe like the out school education place and other student teenager activity place. The smoking is banned in that place. So the youth include the primary school student, middle school student, high school student should involve in this law to monitoring, to push the law. So this is the first one. The next one, So here, because I'm also the deputy director of the Chinese Association of the Tobacco Control. In our association, we have a very strong branch with called this tobacco control to the adolescents. So this is a very strong branch and very activity. They have the network. In the network, they have more than 300 schools. It's like a network. And also so far we have 617 students work in this network. They do some education, they do some communication, and also they have this is some special activity around World Tobacco Day each year, that is stay away from tobacco and is refuse the first puff for the teenager. So this is this whole activity is organized by the adolescents. So next, please. So we also have another smoke-free activity. From our monitoring, from our surveillance, we found even in some cities like Beijing, Shanghai, has a very good legislation. They ban the smoking in the public place like a school, hospital, even restaurant. But we found that in the home, the secondhand smoking rate no change. So we initiate activity is called the smoking-free home. So in some province, like the Guangdong province is a neighbor of the Hong Kong. So it's a very big province. It's about near 100 million people. So the education department, the bureau put the smoke-free in their curriculum. So they ask their primary school student to do the smoke-free home, like the homework. So each student, so they will do
Dr.
that.
Dr. Chang, we're running short on time. If you could sum up in the next 30 seconds.
Sorry,
great.
sorry. Yeah,
okay.
I'm finished.
There's a lot to talk about.
Yeah, I'm finished. So thank you.
Okay.
Thanks for the opportunity.
Thank you so much. Thank you so much. And now we'll move to our fourth speaker on this panel, Dr. Iman Polanan from Indonesia. And Dr. Iman will consider some of the issues that the industry and commercial interests have put in the way of children and tobacco control and ways that those might be addressed. Take it away, Iman.
Okay, thank you, John. And good morning, good evening, and good afternoon. Next slide, please. Next, yes. I would like to see, I think there is, okay. Yeah, the tobacco use, the survey in Indonesia, but actually I just want to mention also about our national research data. There is an increasing tobacco use among children from 10 to 18 years old. But the worst thing also, younger people start using tobacco right now, start smoking, even below 7 years old. This is, we have it in some province. So you can see this is the survey. This is our collaboration also with the CDC, I think, the Global Youth Survey, grade 7 to 12. And you can see here the current tobacco users and also the smoked tobacco. The percentage, some of them above 25%, and smokeless tobacco, they start using it already, and susceptibility also. So the cessation, more than 8 in 10, about 81% students who currently smoke try to stop smoking in the past, but more than 8 in 10, about students who currently smoke tobacco want to stop the smoking. They want to, but sometimes it's quite difficult because the environment, they all smoking. The secondhand smoke also, we have about almost 60% of them, and 66% of students were exposed to tobacco. The problem is the accessibility, the availability. About 80% is really easy. Any shop in the street, so any vendor, any kiosk, they sell cigarettes. So any age, anybody can buy cigarette and also can smoke cigarette. No one will say no. Media also, a lot of media have a campaign. But it's the hidden campaign, a lot of commercial support by the tobacco company. Knowledge and attitude, you can see here. Next slide. Next slide, please. So the empower, this is really bad. So the smoke-free policy, we only get to 0.4. And the taxation is only 58.5%. The empower score for color key, affordability category, see, we got a red one, not become less affordable. So there is less effort from community, from all stakeholders to stop children to export from tobacco. Next. So the empower measure in Indonesia, you can see here, a lot of no one, right? National TV, the compliance, is not really good, and bans on tobacco, free distribution, the compliance is not good, and the tobacco products also is not good. Ban on the corporate social responsibility, also no. So this is a lot of no here from the enforced bans on tobacco advertising, promotion, and sponsorship. Next one. So way forward in Indonesia, the study and tobacco control activities that we take in Indonesia strengthen and enrich the government argument in dealing with tobacco company. Since government and legislation are the one who had authority in making tobacco control regulation, optimize every connection. We have the supportive stakeholders and look for new ways to win the market based on the empowered domains measure. Indonesia's dependence on tobacco industry needs to be reviewed rationally, given that the sector supports a minor proportion of the country's workforce. Realigning this reliance would enable money currently spent on tobacco to be spent on other product services, fueling economic growth and job creation and other competitive sectors of the economy. So I think we need to work together. Yeah, we need to support also from WHO, from all the stakeholders. I think all the government, I think, have to support this. So I can say from the IPA, I think we have to tell all the country members also what's happening in one country that another country have to remind it. I think. Thank you, John.
Thank you, Aman, and thank you to all four of the panelists here. We have about 12 or 13 minutes now for a question and answer session, which will be led and facilitated by Bernadette Dalman. So back over to you, Bernadette. And again, thank you to all the organizers and the participants here.
Thank you very much, Dr. Klein, and thank you, like you said already, to all the panelists who have shared such a rich experience, taking us through these different aspects of the Empower strategy, showing that overall an umbrella legislation is very essential, but then going on to the different aspects that can be influenced through medical professions in their services, but also the medical profession in relation to policy makers at government, as well as then reaching out to the community so that knowledge is there. And we've heard about the power of young people to actually be agents of change. So participants, this is our time to pose some question and answers. If you look next to the chat, you have a little icon that says Q&A. So we would very much like if you write your questions in there, then we can organize them and post them to the panel. I'll ask the panelists now to all put on their camera so you can be seen. And I actually like to start with a question that is answered, but not everyone may have seen that. Maybe Hebe, we can temporarily take the slide off so that the panelists can be well seen. Thank you. But I like to pose the question so that all participants can hear and benefit from it. So Sean Temple has asked, the WHO Framework Convention for Tobacco Control, Article 8, is about protecting non-smokers from secondhand smoke, but makes no mention of homes. Do you think that it should be modified to include homes, given that this is an environment where children are most commonly exposed to secondhand smoke and to the highest concentration? So Dr. Philippidis and Dr. Klein, you already answered that. Maybe Dr. Philippidis, just if you can briefly kind of articulate your main point, and then I'll get to Dr. Klein. And then maybe Dr. Prasad can be ready also to give us a little additional information on this. Dr. Philippidis?
Yeah, well, what I said was that although I understand it may be difficult to actually implement smoke-free legislation at home, what we've seen is that implementing these laws elsewhere in restaurants, bars, cars, workplaces has an impact at home as well, because people are inspired to make their home smoke-free as well. So this has a benefit for children. Of course, it's not perfect and there is still a lot of exposure at home. So it is something that we need to consider.
Thank you. Thank you for that. Dr. Klein, would you want to add?
Thank you. Yes, I would just add, most adults who use tobacco and nicotine products know they're addicted, want to quit, and have tried to do so unsuccessfully, and are willing to try again. And in fact, creating smoke-free home rules is often a way to help people moderate their smoking and encourage quitting attempts. The other point is that many children and others live in multi-unit housing with shared air supply across apartments or condominiums or other housing units. And when you have shared air supply, you have secondhand smoke exposure. And passing rules and laws that protect people in those settings becomes a public health issue around harm to others. And in fact, at least in some countries, the survey data shows that even most smokers support having those kind of rules in their housing units. So I would just encourage people to not shy away from it because of a rights argument for individuals, and recognize the harm to others that goes on in housing settings.
Thank you. Thank you very much for these responses. Dr. Prasad, would you want to add something? There was also a question posed to you. You spoke about 3 countries that had a complete ban on tobacco. Could you say some details around what these countries are and maybe reflect on the discussion we are just having?
Thank you. So a couple of things. During the COVID, a couple of countries have banned outdoor smoking. For example, 15 countries banned use of water pipes in the Middle Eastern region. A couple of other countries banned smoking, cigarette smoking. But then also at the same time, countries like Bhutan that had banned tobacco earlier lifted the ban. What we see, as Philip was pointed out, is that countries that have strictly enforced indoor smoking laws have seen a behavior shift towards smoking at home. Even in the US, the state of California, for example, versus some other states down south, there's a huge difference in smoking behavior at home. So very high compliance in California, very low in other states, just because the smoke-free laws, indoor smoking bans are quite controlled. So that's one issue which we really need to work on in terms of behavioral change, societal involvement, where we want to move on. And then there is a whole discussion. I think you wanted me to reflect on the WHO FCTC question, or which one? In the chat box.
Well, maybe let's continue this conversation. There is actually Felicitas Calomo in the chat is asking, Where in African countries have strong strategies be developed based on this framework? Could you give some examples, because that helps sort of our colleagues in the region to look and say, can we get sort of good practice lessons learned?
Thank you. I think we can start with the 3 island countries, Mauritius, Seychelles, and Madagascar. They were done extremely well. All 3, even before the convention treaty had come into force, they were already moving in the right direction. Then we heard from Kenya. Kenya has done extremely well in recent times. Uganda has picked up. Ethiopia has just moved a number of policies in the last 3 years. South Africa used to be a champion, but has been slow in the last 10 years. So it's a mixed bag of countries. On the Western side, we have Gabon, we have Senegal, we have a couple of other countries that have also made good progress. So the WHO Framework Convention, accelerating it is an SDG target, 3A. And linked to that is the NCD Action Plan of WHO, which has a 30% relative reduction. So there's an obligation at many fronts, which countries are trying to work on and achieve. So there is a strategy by the parties to the treaty, which is the global strategy to accelerate FCTC. So there's already one strategy on that front. And then the support which we give as WHO to accelerate, empower implementation. So these two processes can help accelerate this work in any of the African countries.
Mm-hmm. Thank you very much. So I'm going to switch to another question, and this is actually for the panelists who spoke last. I think Dr. Lutufu, Dr. Jan, Dr. Nyeri, all 4 of you have spoken to the issue that this question implies. So it says smokeless environments for everyone has to come as top-down system approach. This can be achieved by force, but through value-based education. What actions are taken to achieve smokeless society through education? Could I ask our colleagues who were on the panel that has just closed, please raise your hand or start speaking and we organize ourselves.
Bernadette?
Yes, please, go ahead, Dr. Pulangan.
Yeah, the thing is, like the situation in Indonesia, let's say like we go to the center city of Jakarta, most of the public area right now is, smoke-free environment. But if you go to the other city and all the village, all this small town, something like that, there is no rule. Children, anybody can buy even 1 cigarette instead of 1 pack. You go to any shop, to the coffee shop, a lot of, commercial and even support by the cigarette company. So they put a banner over there. So the environmental, so I don't think we can educate this. We just have to stop it by the legal.
Okay, yeah. That's a clear message.
The whole environment is supporting even children to smoke.
Yes. So the importance of an overall legislative framework that sets boundaries is critical, is it? Maybe we can hear some other examples. Professor Yang, you spoke a lot about how you're working with young people education, getting this grassroots voice also to try to influence practices. Would you want to comment more? And I see Dr. Lutufu and Dr. Njeri, you get a chance also to speak on this question. Dr. Yang, would you want to go first?
Okay. So for the how to influence the young people, I think the several things is important. One is we should have an organization like a volunteer organization, and they also we let the young people know the harmful of the smoking, youth smoking and secondhand smoking. And also because they also to work with some education department. So for example, in Guangdong, in Guizhou, we use the different like some routine system, like they will put the tobacco control the problem that into the teaching material. So we ask, it's not like just the World No Tobacco Day, it's like a routine system. So we use a different curriculum, the primary student, grade 1, grade 2, grade 3. So different level of students have the different material. So we can use that to let people know, let the young people know the harmful of the smoking. That's all.
Thank you for that. May I give the word to Dr. Lutufu? Dr. Lutufu, if you're speaking, we can't hear you. You can, yes,
okay.
Please.
I think the answer is both, but my experience is that I started my anti-tobacco ambulatory by treating my asthmatic children's parents who smoked, and after that, the university employees. For 18 years, I've kept an open ambulatory for people who want to stop smoking, and 13% of the people who come to the ambulatory are the family members because of my patients' request after they get my booklets. I think the pediatrician needs to treat the parents of their patients. I think that is very important.
Thank you for that, because that will influence the entire home environment, is it? Dr. Njeri?
Thank you so much. I think I like to think about it as an adolescent medicine practitioner. And when we think about, as Dr. Prasad was saying, when you think about behavioral change and looking at the motivations behind a lot of adults and parents and caregivers, they all seek the best for their children. And not all of them are able to make that connection between their lifestyle having a negative impact on their child's health, especially when you think about tobacco. So also just looking into the motivations and working with adults and working with parents and caregivers about what their goals are and what their dreams and goals are for their children, and being able to link that in terms of those goals with their actions would go many steps forward in terms of promoting a smokeless environment. Because a lot of adults have some sort of understanding of what the law is, either it's been reinforced by the legal system or how things have been established in the community from the top. But from the bottom, it's mainly looking at what their motivations are and really tapping into that to be able to drive that behavioral change that we seek to see in homes.
Thank you for that. So these multiple dimensions, is it, we are learning that need to be tackled. And if we see each other as humans, and even in this conversation, this webinar, is it, there were reactions around the data, the knowledge. So people may be ready to change, but having appropriate knowledge and being supported is very important. Colleagues, we need to bring this panel to conclusion. There are many questions, and within the organizers, we will keep track on that, and some answers may follow to individuals after the session. There was one question on the now shift to e-cigarettes, and Dr. Prasad has already expressed sort of a deep concern within this. We had our colleagues from Imperial College, and there's also Dr. Laverty and Dr. Bin from Erasmus University, who I think are with us on the panel. Would one of you give us a short reflection on this issue of e-cigarettes? Are you looking at that now? And how do we need to place this in this whole sort of effort that is going for preventing exposure to smoking? May I give one of you the word on this one?
May I suggest you, Anthony?
Yeah, thanks, Jasper. Well, I guess, the first thing I would say is with Philippos, we're doing this review, the health impacts of e-cigarettes, which is going to be ready sometime next year. And I think, I think it has been sort of set out quite nicely. The question is really around, is it enabling people to continue to use e-cigarettes, to to continue to use conventional tobacco, or is it driving people to quit tobacco? And the evidence, I would say, is pretty equivocal there. So I think that that it is a debate, but in terms of is it a positive development, really, we're going to need, I would say, more regulation. As has been said, there's not a lot of regulation on e-cigarettes and novel tobacco products in lots of the world. We're going to have to fix that.
Thank you. So this is a space for all of us to watch, is it? What the evidence is that is being put together, that WHO is going to bring out. And it's clearly an issue that has to be part of the narrative, and that cannot be automatically taken as a solution. May actually be part of a perpetuation of a problem. So let's keep a watch on that. Colleagues, I'd like to thank you all for the questions, the responses that have been given, and I'm going to hand over to Shikufi Zonji from the ECD Action Network, the technical lead there, to lead us into some final reflection of partner organizations and what they can contribute. Shikufi.
Thank you, Bernadette. And Bernadette, I just wanted to request if the panelists could take some time to look at the Q&A and perhaps even type their answers right there. That would be really helpful. Wonderful. So in the last few minutes, it's my pleasure to facilitate a reflection from partners. Specifically, if I can request 4 partners to turn on their videos. Irene from the International Confederation of Midwives, Joanna Lai from UNICEF, and Jonathan Klein from the International Pediatric Association. And if I can request the others to turn off their videos, that would be wonderful. Okay, so let's begin. We've had such an interesting, rich conversation. So we've heard about the harmful effects of tobacco on fetal and newborn health. And midwifery services and midwives have a unique opportunity to work with future parents and measures to protect themselves and their child. So this question goes to Irene. Can you tell us how ICM is working with midwifery personnel to address smoking and secondhand exposure?
Well, hello, good afternoon. We are working with a Dutch task force organization for smoke-free environment, also for the children who were born, and we facilitate with all things like videos to make it visual for future parents to see what damage and what harm smoking does to the babies. We facilitate with e-learnings so that they know they enhance their knowledge, but also to show how to have a chat in the room when you do your checkups. But also we have something to do with when they plan a child in advance, like they say preconceptional. There's also to plan a child what to do with your life before becoming pregnant. So that's also a lot of midwives are working with. So I think it's gaining a lot in the Netherlands as well.
Thank you. And so, Joanna, from your point of view, given the presentations that you've seen, what's an insight or a key message that has emerged from you, and perhaps some reflection about UNICEF and what UNICEF is doing around this issue?
Great, thank you, Shikufi. As the other panelists have really highlighted, and also the thematic brief highlights, early intervention among school-going and adolescents matters. And that is something that we really also focus on in UNICEF. Central to this for us has really been shifting from just awareness raising and education to really meaningfully engaging young people in creating smoke-free environments where they're part of shaping the global learning products we develop, defining the strategy of how this content is delivered, and importantly, in driving policy action at the national level that is centered around their needs, their experiences, and social context. Just as an example, this year we brought together young people and technical experts to develop a series of learning modules that focus on NCD prevention. And one of them focuses on tobacco use as well as alcohol use. And these were designed specifically for delivery through schools and also digital platforms. It takes an inquiry-based learning approach where we aim to help young people improve their ability to examine the influences for tobacco use around them in their own context, how they are or not are not protected, to understand and weigh consequences, to identify what kind of skills and strategies they can put in place to make healthier choices, and importantly, how they can also be a part of making a difference in the home and communities. So far, we launched these modules this year. We've been able to reach over 6 million young people through social media, and then 71,000 through the modules on the website. We also roll this out at country level. For example, I know we have a presenter from Indonesia. In Indonesia, we roll it out through an information chatbot that's reached 42,000 young people there. And really, we see this not as static, but a conversation with young people. And some of the things that they've been highlighting that were also mentioned in the Q&A panel really is they want and they need practical, non-judgmental support to quit smoking if they have already started. They highlighted that they know it's not good for them. They even have some motivation to stop, but they really need that kind of ongoing support in the journey. And they also reiterated that the interventions shouldn't only just be targeted at them, but also their caregivers who need the support in creating healthier, more protective environments. And I think just lastly, I want to close because it was also mentioned, young people are really increasingly calling for action around the commercial determinants, particularly in regards to harmful marketing in the digital spaces and also around e-cigarettes. So I think it's been essential to our work for engaging young people. It's great to see the country examples, Brazil, China, Indonesia doing the same, and ensuring that we do so that the strategies we develop respond to the experiences that they have and build their capacity as change agents.
Thank you, Joanna. And it would be, I'm not sure if these resources are open source, if others can access these learning modules. It would be great in the chat to know, where the links are, what languages, what countries. It would be great to have that information. I'm sure that's of great interest to many.
I'll put them in the chat box. Thank you.
Joanna, thank you so much. And maybe we can capture those and send them out when we send out the link in the presentations. That would be great. All right, and now, so over to Dr. Klein from the International Pediatric Association. And so it would be really helpful for me to hear some insights and what you've taken away from these presentations. I mean, you've been working in this area for so long, and it would be, to give us some call to action. What is like a bold action that we need to do to advance this agenda through our networks, organizations, and countries? So it would be great to have some insight, something new that sparked your attention today.
Thank you, Shakufi, and thank you for ECD Action Network for helping move this issue. I think my takeaways here are a few points. First of all, tobacco and smoke exposure causes major health risks, and it's completely preventable. And I think the evidence base has existed for quite some time, and it continues to get stronger. But when it comes to action, the evidence base is actually quite sufficient to act. And addressing tobacco and secondhand smoke and electronic cigarettes or vapes and other products, when there's strong evidence for harm and when there's evidence it can be prevented, we really need to act. It addresses both the direct outcomes of disease, but also significantly affects the child survival agenda and the nutrition agenda and the other maternal and child and newborn health issues that we know are important global goals. As we saw from some of the presentations, there's global youth tobacco survey data that WHO helps support. There are the Empower measures and the fact that there's reporting on what's happening in each country. Those data already exist also, and they can be used for evidence-based advocacy. But there's limited awareness of the integration of tobacco control issues into some of the other maternal and child and newborn health issues. And this is, I think, where this session and others like it really need to help make that connection between between nutrition outcomes, between newborn outcomes, with what happens with addiction. This is where I think professional associations, pediatrics, midwifery, OBGYN, all of the primary care organizations that address frontline health workers and their education and their content can be part of this, because tobacco control is one of those issues that needs both personal individual interventions by frontline healthcare and policy interventions by governments and sub-national governmental units. It's local, it's also national. Whether it's counseling around cessation or smoke-free homes or cars or smoke-free public places to protect children, or whether it's rules and laws that help do that, we need to put all of the products into those rules and laws, and we need to advocate for them, but also address the individual preventable risk. So governments are critical in spreading this to scale. They can prioritize public health, and healthcare providers, clinicians' voices are very important as advocates. We don't have a commercial interest in this. Our commercial interest is in preventing these outcomes. Governments can create good advocacy and training and dissemination, but we need that advocacy for children and youth throughout the systems, both for clinical practice and for education. So I think I close with pointing out that partnership between government, both on the tobacco control side, but also broader in health and public health and in other policies, along with that advocacy from professional voices, can help address the integration of these issues. Having healthcare professionals as champions helps move this forward. And it's important that we keep asking the right questions, both about individual exposure, but also about the policies that our governments have. The role of IPA and the other global professional organizations is to help bring those partners together. And with WHO and UNICEF and other partners here, I hope we'll continue to be able to do so that every child can grow up in a smoke-free environment, and we can end the epidemic of nicotine addiction and have a true smoke-free generation. Thank you.
That's a beautiful vision for all of us. Thank you for that, Dr. And to all of our partners. And I think that gives us a really concrete list of what all of us can do. And I think we can all find something to do here. So thank you so much. And now to take us to the end, this is incredible. We're right on time. Dr. Anshu Banerjee and Dr. Vinayak Prasad, over to both of you.
Thank you very much, Shikufe. And I just wanted to come back to the issues that we've discussed around the commercial determinants of health, let's say, and really around advertising, targeting children, targeting the targeting done by tobacco companies. And the WHO UNICEF Lancet Commission highlighted really that this was one of the areas that we needed to focus on if we wanted to improve child and adolescent health. And so I think it's very important that we look on how to do this better. We know that it's not only for tobacco, we know it also applies to alcohol, it applies to sugary beverages, it applies to food items, it applies to breast milk substitutes, etc. But this is becoming an area that we really need to focus on. And as WHO, this has become an area that has gained, let's say, traction as well. The other thing is really to I think, see how we make, how to say, the issue about role models and how to address that particular issue. I think it is important that not smoking becomes the norm and that it becomes a normal value, let's say, and how do we improve that? So, of course, legislation is one area, but it's also the implementation of legislation that's very important. And often this is where the gaps are. The laws are in place, but they're not being implemented. There are no consequences for people not adhering to the legislation, for companies not adhering to the legislation. And I think this is an area that we should really support at country level how to do that. The other area is around programmatic implementation. And I think, in our antenatal care programs, postnatal care programs, in our school health programs, we really need to look at how we can strengthen this and these components and make sure that, because there's so much evidence out there about the impact of smoking, but also the indirect impact of secondhand smoke, that we need to strengthen these platforms with the right kind of tools and support them to address these issues. So maybe just as a final comment, I hope that everyone will make use of this policy brief, and anyone who at the country level would like to have support to implement this, to have a policy dialogue at country level with the government, with the ministry, please reach out to us, and I'm sure that we, including all partners, would be happy to support you, have that policy dialogue, and make a smoke-free environment a reality. Thank you. Over to Vinayak.
Thank you, Anshu, and thank you, colleagues, all of you who've been very actively involved in this discussion. Let me just give a reflection. 2 years ago, we had a trends report which showed that 32 countries were on track to reduce tobacco use by 30% relative reduction. We were just looking at fresh data, thanks to COVID. Maybe it's a positive outcome of COVID, is that because of the fear, there are more countries that are on track, almost double. So I still wouldn't despair that tobacco control is not happening. It's happening, it's moving on. But in some of the large countries where the industry is really well entrenched, we've been seeing Tanzania coming up, Indonesia is also there, and China, of course, is unique because the China tobacco is owned by the government. So in these large cohorts of tobacco use, when China, Indonesia make up almost nearly 30% of tobacco use in the world, there's not much progress. How do I get the governments to engage? How do I get the civil society to engage? How do I show them the value of tobacco control to child development and overall development? I think those are some issues which we definitely need to figure out. But then I wouldn't rule out countries in the European continent, for example. They're the worst performing when it comes to the women tobacco use. The girl child is into smoking as much as the boys. So that is a huge concern for the Western world. Whereas Southeast Asia is seeing a good decline, for example, in the last 10 years, Europe is not seeing that kind of a decline. So there are different competing challenges, and we really need to think a little more as stakeholders. It's important that we look at advocacy strategies tailored to the needs of the country, not just one set of strategies like FCTC commitment or the thematic brief on its own, but look at the environmental and economic aspect, which also resonates very high. Tobacco is the second most polluting substance in the world after a plastic bottle. So how do we then use that as a narrative? I think those are very important pointers we want to reflect on. One thing we didn't discuss and something to see is that more than 8 to 10% children, teenagers are into tobacco use in a large number of countries, but they're not getting the brief advice. They're not being counseled. And I think as pediatricians and public health officials who have great and good access to this group, we should definitely be able to do the brief advice counseling of the children. So I think those are extremely powerful evidence-based interventions we can work on. And this thematic brief is timely because it is well documented, looks at some of the progresses which have already been achieved by Brazil, for example, and a couple of other countries which have now made good progress. What I want to close down with, maybe you want to put the slide up, the last slide, yeah, is that this is the set of links where you could get the brief, but also on the Empower measure for those who want to read more about the electronic nicotine delivery devices. A lot of questions have been asked. We have a whole report which we came out in July this year. So do look at them. Our trends report is going to come out later next month. So we'll also be able to update that. And then, of course, the websites from For Nurturing Care and EGDAN's links also have a lot of useful information. So I just want to thank, in closing, I just want to thank Anshu, Bernadette, Sheila, but also the colleagues from UNICEF, EGDAN, and above all, of course, Philippos and the whole Imperial team, and then Hiwi from my team, who really worked hard to bring this all together, including the workshop today. And I do hope that we should be able to go drill down further. If there is a demand for it in any particular country, then we're more than happy to go and see how the brief can be used for advocacy. And we work through Anshu to see how we can better support this group on the ground. I believe the presentation and all will be shared in due course. So thank you once again. Back to you, Bernadette.
Well, thank you, everyone. I think with that, we can close the webinar. We thank you, everyone, for joining from all over the world, all across time zones. And we look forward to continuing this dialogue in the future. Thanks, everyone. Thank you to all the panelists. Thank you, everyone.